It's good to see you this afternoon, though it's virtually, but it's good to see you. Today we're going to have a very interesting topic. We're going to talk about promoting behavior change to prevent COVID-19 disease. And we're going to have a very interesting panel that will take us through that topic. People who have really done a lot of extensive research in that area. They'll be able to take us through that. Mariana, Edward, Jane Mwangi, hello. It's good to see you, that you're here. We appreciate that you always find time to attend the sessions, and I hope you're learning something from them. Rebecca Soy, we don't need your details. Once you log into the session, we get your details immediately you log in. And every time, and Nicholas also, when you log into the sessions, we automatically get your details, so you don't need to send in your details. So my co-host, Dr. Anna, is here with me today, and I'd like us to start off. So we have Professor Modoni Madai, and Dr. Oscar Gidua will be taking us through this session. Professor Madai, hello.
Hello.
How are you doing?
I'm fine, thank you. I'm fine, thank you.
Good.
Yeah.
Dr. Oscar Gidua, hello.
Hi, Doc.
Hi, how are you?
Sorry, my mic was muted.
That's okay. You're doing
Good
well?
to be here. Yes, thank you.
Okay, fantastic. I think we're ready to start. So I'll let, I think it's Professor Madai who's going in first, and then we have Dr. Oscar who will also give us we'll also talk about the promoting behavioral change and what the work they've been doing in Kenya. So Professor Madai?
Okay, I have some slides I would like to share, so I will do that now. And you tell me when you can see them. Can you see my slides? Okay.
Yes, I can see your slides.
Okay, I just need to make them. Oh gosh, why aren't I getting a I don't seem to be able to make it a slideshow. That's strange. I'm trying to make it into a slideshow, and for some reason, nothing is happening. Sorry, I'll just share it like this, because I'm not able to make it into a slideshow for some reason. Is that okay?
That's okay.
I don't know what has happened with maybe it's the format that I'm using. I don't know. So let me just do it this way. What I just did a few slides, and I wanted to talk about behavioral change and protective practices in the public sector. And this is at the beginning. As you can see, this is one of the behavior change that we are expecting. Now, my objectives are to look at why we need to change a form of behavior, the need to change a form of behavior, and what are the theories of behavior change. Because if we're going to be looking at a change in the public sector, we need the backing of the theories and the area of psychology, sociology particularly, and behavioral sciences have several theories on this, and this helps us to know if you want to start something on behavior change, what are the strategies that I need to apply? What do I need? What kind of theory do I need to ground myself on, or to link myself to? So the kind of behavior change we are talking about when we talk about the pandemic COVID-19, we are talking about the physical distancing, frequent hand washing with soap, sanitizing, not always possible, wearing a mask in public spaces or places. And these are the main things that we are asking the public to do in order to protect themselves and to protect the other. And I think it's important to notice it's not just about protecting self, but also protecting the other, because then that raises quite a few questions. So behavioral change theories and models explain the reasons behind alterations in individual behavioral patterns. Why do people move from A to B? Because change is about moving from where you are to another position. It can be just gradual movement, or it can be adopting a completely new forms of behavior that you've never done before. Something like physical distancing is probably something you've never heard of. While in some countries, wearing masks has been there even before in public places like in the Asian countries, this is completely new for us in the public sector. We know about wearing masks in the hospitals, but about wearing masks in the public as you walk, as you sit in a bus, this is completely new behavior. Hand washing has always been there. It has been recommended by public health for centuries, but people didn't really take it seriously. They washed their hands when they went to the toilet, or when they come from the toilet, or before eating. But frequent washing of hands, so that whenever you're touching things, after you wash your hands, this is completely new behavior. So okay, I'm ready. Oh, did I go backwards? And look as if I'm going backwards and forwards. Wow. Okay. I don't know what's happening. So let me give you a few examples. I will not look at all the theories because there are very many, and they apply to different things. They apply to education, parenting, criminology, health, and ours is about health mainly. So I will not cover all of them, but there are some 4 theories which apply to my understanding. One is the learning theories, the socio-cognitive theories, and the theory of reasoned action, and most important, of course, the health belief model, which we have been using in public health for decades. Now, if we start with the learning theory, the question here that we want to say is, what are we as health workers? What role are we playing in order to influence people in the public sector to protect themselves, to protect each other, so that they don't end up becoming our patients and swamping our working space because they have become infected? What are we doing? What is our role? We actually have a role. And some of the learning theories might bring some insight into these questions. For example, are health workers educating patients and demonstrating protective skills? Because according to the learning theories, complex behavior is learned gradually through the modification of simpler behavior. For example, if you want to wear a mask, first of all, there is how you remove your mask from the packet. And then there is how you put it on your face. And there's how you remove it. Are we actually educating the public? Even hand washing, as we have seen, and as we know, if you're health providers, there are certain skills that go into hand washing. So are we educating the people we come into contact with in the form of demonstrating, not only telling, but also demonstrating, even if these demonstrations are video demonstration? And I know I have seen a lot of videos on how to wear a mask, how to wash your hands. Are these a demonstration coming from us and going beyond our WhatsApp group to the public? So the other one is that learning theory, individuals learn by imitating behaviors they observe in others. Are health workers modeling appropriate behavior? We have heard about, or somebody told me a story, which maybe it was not a true story, about how somebody went to a party and there were doctors who were invited to this birthday party and they went at this time and they all came wearing masks, but they left their masks at the door. And this person was asking, is there something these doctors know that they're not telling us? You know, so it's as a health worker, ask yourself, am I modeling appropriate behavior? Because people are looking at us and they want to see how we are behaving. So if we are the ones who are also attending parties, then they're going to start thinking, maybe there's something we don't know. Maybe it's not that, you know, what is being said. Okay. The other one is about rewards and reinforcement. In the learning theories, this is a really important thing to ensure repetition of desirable behavior. Now, question, are health workers complementing appropriate behavior? When your client comes, your patient comes, you know, in psychiatry, sometimes you talk about clients, and in psychology. Do you compliment them for wearing a mask? If they come through the door and first use your dispenser, do you compliment them for that which they're doing? Because this is a kind of reward, a compliment that is going to reinforce that kind of behavior. So, just a brief one on Skinner's rats. If you've done your psychology, that whenever the rat presses the lever, they get a pellet. So it's about reinforcement and reward. You can just forget about that picture. Now, the other one is about the social cognitive theories by Badura. And one, he says that change is about, behavior change is about the interaction between the environment, the person, and the type of behavior that is expected of you. So you are the person, the behavior is what kind of behavior do we expect from people? And what about the environment? Does the environment support this behavior? And this is a question which will come again and again, and you've probably heard about it. Is the person motivated enough? Is the environment, we've talked sometimes about our informal settlements and other areas where there is no water to drink. And that environment cannot support hand washing. There is no water to drink. So where is the water to wash hands? Or you're saying people should wear masks. Do they have the resources for these masks? Although it seems like a lot of people really have managed to get these resources one way or the other. So change is about these interactions. It's a complex interaction and can even become more complex when what you do changes the environment. For example, and this is where as health providers we come in. So my feelings and my thoughts, where I feel at risk will indicate my behavior. And my behavior will interact with my personal characteristics and will determine, will be also influenced and be influenced by the social environment. And if we want to influence the social environment in which we are in, this becomes important because my behavior is going to influence, and this is what I had mentioned before. So all these theories somehow overlap one way or the other, but it boils down to the fact that my behavior, my personal characteristics, whether I am a person who greets my patients now from a distance, but also compliments them for what they are doing to protect, you know. So there is that interaction, which is so important, and where we, each of us as individuals, have a role to play. Then there's the question of self-efficacy. And this becomes another important thing if you're going to change. If people are going to change their behavior. One, can I do it and persist in doing it? These are the things. This determines self-efficacy, whether I can do it and I will be able to persist doing it. It's like people have said, you know, talking about social distancing, and yet I live in an environment where people are really packed together. Can I really do it? And will I be able to persist in doing it over time? And this determines the choice of activities. If you're given this and that and that and that to protect yourself, which one will you pick? Unfortunately, in this case, most of the elements that we're talking about come together and they're all important, but some people are not going to be able to pick certain activities. They have to be presented to them in a way which they feel they can do it. And if they don't feel they can do it, they're not going to put much energy into doing it, okay? And whether they persist or not, when there is adversity, or will depend on whether they feel they can do it. So these are all factors that will go into behavior change. And then there is the other one of reasoned action. We're saying human beings are rational people. They have intentions, but these intentions develop from the individual's perception of whether a behavior is positive or negative, and whether there's social pressure. That means if in the context in which you are, people don't frown at you if you're not wearing a mask in public, then you're under pressure to wear it. If you go to a supermarket and the cashier is not even wearing a mask, people start walking around with them around their chin, then there is no social pressure to wear them. The only social pressure is to wear it around your chin because that's what people are doing, okay? That is, how does society perceive of this behavior? Now, the last model I'm going to present, I didn't want to present too many models of behavior, but this is so important, but we know it. This is the health belief model. And here you can see some of the previous public health applications, not all of them. Tumia choo, use a condom, drink clean water, okay? I'm sure even hand washing has been there, but maybe not as emphasized as it is now, because we had those hand washing days with Dettol, but we have never had some of these things like physical distancing or wearing masks, as I mentioned. So let's see how the health belief model can be applied to our COVID-19 pandemic situation. What the health belief model does is it attempts to explain health behavior in terms of individual decision-making based on their attitudes and beliefs. The individual's perception of a threat, their belief that that behavior you're telling them will reduce this threat. And you probably know that a lot of times, if you go back to that picture with the chore, is that the public health officer has gone to the village and told people to build chores. And if they don't, they're going to be fined. But they did not see how this behavior was going to improve their health. They did not perceive any threat in not building a chore, so they built the chore for the public health officer. And when he came to check, it was always nice and clean. So these are very important aspects when you want to change belief because of the health implications. So with reference to our COVID-19, the COVID-19, not ours, everybody's COVID-19, the global COVID-19 pandemic, the question is, what are people hearing, thinking, and interpreting with regards to themselves? Perceived threat. Am I susceptible? Am I at risk? Do I feel that I am at risk? You have had some areas, maybe not in Kenya, I think I have heard in some other country where they said that there is no such thing anyway, it has always been there, and so on. And it doesn't affect this group, it affects this group. It is only old people who are threatened. It is only people with comorbidities that are threatened, and so on. So what are we hearing, thinking, and interpreting? Am I susceptible? Is it severe enough to harm me? And we've been there before with HIV. We've been there until many years down the line when we have things more under control. Am I susceptible? Can I be affected? And is it severe enough to harm me? Perceived benefit. Will the proposed behavior protect me? And this is an important question, and this is important in the messages that you want to deliver to your patients and other people in the public. How are the behaviors you're telling them going to protect them? They need to understand, what is this washing of the hands? Why can't I drink that water? You've heard stories of, oh, you drink a lot of water, okay? Why do I have to wash my hands? Why do I even need a mask? And this has come up a lot because there have been a lot of messages going round that, and this is where we started, even with WHO, the mask does not protect you. It's not an N95, it's not even a surgical mask. And then they started saying, yes, but if we all protect each other, if I wear and you wear and the other one wears, it does protect the other person. But that is, I leave that for the microbiologists and others to clarify. But the people have to understand, will the proposed behavior protect me? Perceived barriers, and this is where correct information is so important. We are living in a time which has been called the infodemic, because there's so much information coming in and so much of it is so weird and so not true, such false news and fake news, but they are everywhere, and we are spreading them a lot. Even health workers are doing that, spreading fake news so that people no longer know whether the behavior they are being told to adopt is actually protective. Perceived barriers, and these are important, and these have been brought up in our setting in the low and middle income countries, that how is the behavior going to affect me socially and economically, and most important, economically. So that is a real issue. Now, cues to action say, what am I seeing or hearing media messages? What media messages am I getting? What am I hearing on my social media that would make me want to adopt a certain form of protection? And lastly, self-efficacy again. Can I really do it? Do I have the means? Do I have the resources to persist on doing it? And that is so far the end of my presentation. And I'm very sorry that I wasn't able to project in slide format, in a slideshow format. Thank you very much. I will wait to hear the questions afterwards or comments.
Thank you, Professor Madai. That was a very good presentation. Really learned quite a bit about behavior change. And I like this last aspect, the health belief model to COVID-19, because you've just brought out what we see in the public or in the social media forums, both from the healthcare professionals and from the public. We believe the healthcare professionals are also part of the public, and they're allowed to react the way they usually react sometimes. So I'd like to hear from Dr. Oscar Gidua. Remember to put your questions in the Q&A section. Then we'll be able to address them. CPD questions, Kennedy, we will address them later at the end. So Dr. Gidua.
Thank you. Thank you so much, Dr. Kalondu. This is such an amazing time. And thank you so much, Professor Mathai, for that very succinct introduction to behavior change as well as the health belief model, which I believe would really help us if policymakers and people who are in positions of power can actually adopt to actually inform their decisions. So far, I think we're doing what we're doing. However, I think we could always improve. So today I'm taking a different perspective, and I'm coming from a different angle. And if you allow me as well, let me share my screen as well, and we'll talk about. Let's do it. Okay, there we go. Great. So we'll talk about the non-pharmaceutical interventions and behavior change during the COVID-19 pandemic in Kenya. And I would like to begin by acknowledging the work of my colleagues and the work with my colleagues in developing this work. So today I'm going to be the person who talks about what we've been doing on the ground. So let me see if we can be able to move it forward. Absolutely. There we go. Okay, good. So what will we do? We'll talk about the context under which we are speaking about this. Of course, all of us are intimately involved with the response in this country as a frontline healthcare worker. Also, we're going to contextualize what the Kenyan interventions have looked like so far. We'll talk about how non-pharmaceutical interventions work. And then we'll talk about something Professor just talked about a bit from the health belief model, which is the perception of risk. Then we'll talk about something interesting, the role of security agencies, and then how Kenyans have responded to it. And then we'll end by giving some conclusions as well as recommendations of what we really believe that should be happening so far. All right, great. So without further ado, let me talk about a bit of our introduction. Sorry, this is well, of course, for those of you who don't know me, I'm Dr. Oscar Gidua, and I'm a forensic psychologist. I'm one of your good partners now. It has been a privilege to be with you over the last about 6 or 7 weeks. We've been working really hard to see if healthcare workers can be involved from a different perspective, to take part in their own interventions, to take care of their own mental health. And today we'll deviate a bit and we'll see how can we, are we seeing these things in society, or are these things that are just being fabricated somewhere? But thank you, as I always do every time. I told you I'll be telling you this every time when we speak. Thank you for the hard work that you're doing. And I'm really, really proud that to be associated with a group of people like yourselves who are keeping our country safe. Let me give the context of this work and say that it is not me who is the sole author of this work, so I will not take all the glory, please. However, we're a team of people who happen to also coincidentally be involved with the work of the Mental Health Task Force, whose report was released yesterday. And the team, we are led by Professor Lukoya Twoli, who will be joining us at some point today. I know he's in another meeting right now. He would have loved to be here to kind of offer direction, but he'll come. There's, of course, myself. There's Dr. Boniface Chitai. There's also Dr. Alfred Gitonga. There's also Dr. Simon Juguna, who's the Director of Mental Health at the Ministry of Health. And we also have Dr. Linget Ongeri, who's a lead researcher at KEMRI. And finally, last but not least, we have Dr. Frank Njenga, who joined us a couple of weeks ago, if you can remember, in our discussion when we had our colleagues from Washington discussing how they've been dealing with their mental health. At the beginning of the pandemic, this team of people, maybe because we realized that, maybe because of where we sit and what we do, we said, can we start tracking the behavior of Kenyans? Because we're all in the mental health space. Everybody I've mentioned, there's a psychiatrist, I'm the only psychologist. And we said, can we really try and see how Kenyans are going to be responding as this pandemic moves forward? So we started a thing, and we have been able and privileged to be able to author three larger papers, as well as one large policy document, which we'll be sharing with the Ministry of Health, as well as with Kenyans, which is authored by our professional associations, with us being the lead authors on it. But then the papers that we've come up with, incidentally, the first one is this one on non-pharmaceutical interventions and behavior change. The second one is about treatment and interventions and how they've developed, especially in the mental health space during this time of COVID-19. And then the last one is about the interplay between our cultures and spirituality. There have been questions about, oh my goodness, they buried him in the middle of the night. That is not what we do in our culture. Or questions of, who does that? Why would they do? There's all these social media posts that you're seeing about saying the dignity of human beings, why are people being buried the way they're being buried? So we're really looking at this behavior of our people, and we are saying, how is it affecting our response to the COVID-19 pandemic? Of course, we've also looked at the government response, and so we're trying to track how government is responding and how people are responding to the government response itself. So that's a bit of the background. Of course, you know how the coronavirus pandemic started, and so I'm not going to educate you on that. You guys should actually be the ones telling me more. But of note is to know that 11th of March, which is just a few months ago, so we're April, May, June, July, 4 months ago, 4 months ago, the problem was not as big as it is right now, and that is when the WHO called it a pandemic. Before that, they'd not really mentioned it as a pandemic, but they'd really seen some differences and a disease that was a pneumonia being caused by a novel coronavirus. But then for the first time, they called it a pandemic on the 11th of March. So for us, that's when we started knowing this new guest as a pandemic. So in response, of course, WHO came up with all those behavior change ideas that you've heard from Professor Mathai, what she's talked about, the hand washing, the physical distancing, all of those things. So they came up with those as the ideas. However, nobody was agreeing on what should be done. And that's where the beginning of our starting to almost lose the fight came. Because when scientists do what I call paralysis by analysis, the problem is that the common person on the ground does not understand that level of discussion. So if in America they're saying, let us breathe, in Europe they're saying, let us continue to get herd immunity. In some other part of the world, they're saying, let's lock down totally. If in South Africa, they're saying, let's lock down. In India, let's lock down. In fact, let's even close all the bars and not give anybody alcohol. What ends up happening is that many people, because of access of this epidemic, what Professor was calling the infodemic, you find that people go online and they come up with all these random things. And in Madagascar, I don't know how many of you have been following the story of Madagascar, just to digress a bit. Remember when they started with the mitishamba leaf, and then everybody said, in all our compounds, we have this thing, let's take it, we'll be fine. I looked at their numbers yesterday, and the same president that was marketing that product is now telling people to social distance, to keep away. So basically, at the end of the day, we are seeing different responses from different governments, and this is a really good place to start for us, okay? Wearing of face masks became a big thing, and I know some countries started shouting hooray and the way they've won the fight too early, and some people said these people are talking a bit too fast. So you find countries like Singapore, you find countries like Poland, countries like New Zealand, although New Zealand has actually really done a good job. But some of those the other countries that seem to have won now seem to be having an upsurge in numbers of coronavirus infections. All of these are determined by behavior change. But then at the back of all of these directives is a thing that I like to ask people: how are human beings related? You see, we are social beings. And because of being social beings, somehow we are unable to distinguish between being told something because of our health and being told something because someone doesn't like us. So what happens is that people just decide, you know what, I will defy these orders just because for me, like in Kenya, what are we saying? In Kenya, we are saying, afadhali nikufe na njaa, afadhali nikufe na COVID badala ya kukufa na njaa. So that's a language. You start hearing people talking like that, then that tells you how they're going to respond to the pandemic. And I think it's worthy for us to note. We really need to put that at the back of our minds. Okay. So moving on. What did the government do? So I'm not going to take you through all these boring things because you are Kenyans and you know exactly what we went through. But it is important to know that these were directives that were coming from the head of state and the Ministry of Health. However, all of them were geared towards mostly non-pharmaceutical interventions and what was supposed to be driving the behavior change. So the first thing that was said is about personal hygiene. That's why we have all those banners talking about commercial corona. It was about social distancing. It's about closing of schools. So we had all these schools that have closed now, which have closed until next year, January. So people are saying, oh my goodness, what's going to happen? Also, there's also the idea of the flexible work from home policy. So people who could work from home were told by government and said, look, if you don't have to go into your office, please work from home. It is better so that we can reduce contact with each other. The other thing was about the curfew, which people received with mixed reactions, but that's actually another one that was instated from 27th of March. Also, one of the ones that Kenyans are not really talking about is what is called the 8-point economic stimulus program. So when people are saying serikali wametuambia tukae nyumbani wanatusaidia aje, the reality is that government has started doing something in 8 points, and those ones can be addressed differently. So if you have a chance, please go online and look at that 8-point program, and you'll see exactly what those points are. But basically, there's cash transfers to vulnerable families, there's climate change, there's money to small-scale farmers, and there are many other money-related interventions which are supposed to stimulate the economy to prevent it from actually collapsing during this time of the pandemic. Then also, the Kenyan response looks like it's falling in between a moderate response. So I would like to call it probably a lockdown light. So when people were asking the president before his speech on the 6th, Fungua Bwana President, Your Excellency, tufungulie, the reality is that we actually were having a lighter version, because there are countries like South Africa where there was something called a total lockdown. And it's interesting because after they opened up after the lockdown, I don't know if you've seen their numbers recently. Yeah? The numbers surged and they're crazy. And we'll talk about why we think some of these things are happening. Now, how do these behavior change non-pharmaceutical interventions work? Well, they're meant to delay the effects of the pandemic, to give us time to respond. That's the first thing. So it's not about killing the virus. It's more about delaying its effects. So knowing it will still affect us, but we just want to delay it so that we can have a way, we can have a chance to think about it, okay, and how to respond. The second thing is to reduce the number of people who are exposed, because the fewer people we have who are exposed with the virus, therefore, the fewer people who will be infected in total at the end of the day. And lastly, NPIs also reduce the number of deaths that are experienced from people who are infected. And the reason why is because the hospital system and the health system will not be overwhelmed. This is the point which was talking about, every news media anchor was talking about flattening the curve. But if you ask them what they meant, they really can't tell you. But I can tell you for a fact, flattening the curve meant let us not overwhelm the health system by having too many critical patients seeking help at the same time. So the idea is that we know we will have critical patients. And that's why you had the president saying that every county needs to be ready to receive these critical patients, so that now we are not, I think even Kenya talking about flattening the curve. If you don't have those ICU and isolation beds, I mean, there's no even curve you're flattening. You really don't even have the capacity. So we bought time. The last 4 months were just about buying time so that we could create the capacity. The counties that listened have done it. Some others are trying to catch up, and hopefully will increase the capacity both in private and public sector to be able to do that. And there are 4 things that normally are agreed that are the non-pharmaceutical interventions. The human surveillance, which is about, diagnosis, case reporting, contact tracing, all of that. There's also patient management, where all of you come in. And of course, I know some of you are also in human surveillance. So patient management in terms of isolation and social support services to the isolated. There's also contact management, the idea of quarantine, sheltering and contact tracing. And then we have community restrictions like the ones you're seeing now, the school closure, the workplace closures, the cancellation of group events, or limiting the number of people in groups. So these are actually world-class, agreed on non-pharmaceutical interventions. So when they're said, it is not that the president or anybody does not like Kenyans, but it is because when these are done, they are actually known to actually be to work, and to be known to be things that help in the middle of a pandemic. Okay, now, so for us to understand how Kenyans are reacting, so what we did is we decided, let's look at Kenyans and let's classify Kenyans by way of how they're actually even internalizing this information. Okay, so we saw that at the end of the day, there are 3 types of Kenyans. And before I talk about the types of Kenyans, do you know that according to the health belief model, that idea of risk perception, if I don't think I can get COVID, do you think I'll actually comply with any of the directives? If I've been told, like in the beginning of the pandemic, if you're Black, if you're African, your immunity is high, you can never get COVID. If you drink mwarubaine, if you go to a mganga fulani, if you pray, all these things, if I perceive that there's something I can do to prevent it, which is not a non-pharmaceutical intervention or pharmaceutical intervention for that matter, then it means that I will not even be wearing masks in public. I'll be fighting with police left, right, and center. Why am I not wearing a mask? I will not social distance. I will not adhere to any of those directives. And so for Kenyans, there's a very interesting thing that we've seen occurring. So the first group of Kenyans are the majority of Kenyans. Kenyans are listening to the government directives, and they're actually following what they're supposed to do. They're social distancing, they're washing their hands, they're wearing masks when they're in public, and they're and most of these Kenyans are the ones who believe that the government or people in power have their best interests at heart, especially the leadership in health. So they actually say, okay, if the Minister of Health has said that, if the Director General of Health has said that, if our doctors have said that, then I probably should do it because it's good for me. Now, the second segment of Kenyans are the ones who don't even need to be told by government to do that. They're people who understand at their heart by actually reading and by going deeper and seeking out information, and they're understanding the gravity of the situation. So what are they doing? For them, they're saying, okay, let's do that. I will do it because of myself. So the first ones are the ones who are doing it because of being told. The second ones are the ones who are doing it because from inside themselves, they believe they should do it. And then there's a third group of people who a lot of Kenyans fall under this one, that comprises of people who look at it as a foreign problem. And so what do you hear about that in narratives? You hear, mbona tulikuwa tumeachilia ndege zifunguliwe, kama tungekuwa tumefungua, hiyo ugonjwa ilitoka China na imekuja. Now the last time I checked, I've been seeing it coming through Namanga border, Busia and all. So it's not even about aeroplanes, but Kenyans are saying that we made the mistake because we left the airways open, and that's why it was brought from wherever it came from. And then there's also another narrative from this group of people who are saying, actually, it does not affect us. It only affects those people who travel in aeroplanes. And that is why you're hearing now the Ministry of Health and other people talking about the localities where the disease is being found, or the infection is being found, to start dispelling that notion that you can only find it in Runda, Lavington, and Muthaiga. Okay? Now, the idea of that third segment came from, this whole, there's a very political thought that it's a Chinese problem, okay? That because China are the ones who started it, it is their problem and we don't care. And so therefore, what is wrong with them, and why should I, as a Mjengo worker, be shielding myself? For me, I need to be fending for my family. I've never even been outside this country. Why have you brought me a problem? So it is not mine, okay? So the problem with this narrative is that it affects people's perception of risk to imagine that they can never get the virus. So they don't know that you cannot negotiate with a virus politically or through ideology, okay? So that's the one thing we're seeing. So then also the reality we have to face, my colleagues, is that there's also what I call the hierarchy of concerns. For many Kenyans, will they, if they're living with under $2 or 200 shillings a day, will they prioritize buying a mask, or will they prioritize buying unga? And that is a question that we really have to really think about, even as we are trying to effect some of these non-pharmaceutical and behavior change interventions to combat COVID-19. That in reality, there are Kenyans who are suffering, and they really are asking, even as you tell us with your good English, all of these other interventions, how about my food? How about my eating? And so that's where we have to also think. And even if we don't agree with that perspective, to just listen to it, okay? And in fact, for them, they're saying that we have other things, cholera, HIV, we have like even Kalazar and floods and other issues like that. And so they're saying, why should we stop everything we're doing because of this one disease? Our life is constantly full of other diseases and other illnesses, and you guys don't ever lock down the economy because of that. So that's something to consider at the back of our minds as to why some Kenyans don't imagine that this is going to affect them the same way. Now, let me talk about one of the things that we've seen around the world, and the whole world has decided to use police officers and military officers to be enforcers of non-pharmaceutical interventions. It's very interesting because even from when the World Health Organization declared it a pandemic, what you started seeing was lockdown orders, left, right, and center. You can't leave this place. Even in Kenya, we had the cessation of movement, isn't it? So the police officers were manning all these roadblocks, so they were walking around at night. And so what has happened is that the states around the world have started relying on security agencies to enhance a public health directive. So that's a very interesting interplay if you start thinking about how officers operate. And because they're not trained on how to handle pandemics normally when they're being trained, that's why you saw what you saw at the Mombasa ferry at the beginning. That's why you saw some of the cases of brutality that you've been hearing about. But it's not really because they want to harm people, but it's because for them, when they're given an order, they have to enforce it in its totality. So I think we have a role to play in educating them that, you see, even if I was to attack someone or intervene with somebody, I also stand the risk. So even as vulnerable as you are as healthcare workers at the front line, the other colleagues you need to think about are security officers, because you guys are working on this pandemic from different perspectives, but also on the front line at the same time. So there's a term that has come up, which is interesting. It's called the COVID police or COVID military, based on how now deployments are being handled around the whole world. And internationally, we've seen many things. So how are people responding? As I come to an end, sort of to see if we can have some discussion. How have people responded? We've seen, like in places like South Africa, we saw things like looting after the lockdown went on for a long time. We saw a lot of increase in crime. But then in Kenya, we've seen most people being compliant until toward the last maybe 2 weeks. You started seeing people getting a bit tired. They started flouting rules left, right, and center. In fact, near where I live, I won't even say where that is. The bars have been operating. People have been dancing, and church services have been continuing. It's almost like people have decided, you know what, we just need to go back to normal life. But here's the interesting thing, that people routinely do not do what is good for them, and they refuse to cease behavior that is bad for them. Even when by drinking excessive sugar, you can develop complications like insulin resistance, and therefore type 2 diabetes. When I don't know why we're expecting that just because of COVID that people will change their habits overnight. And this is the thing about the human condition. We seem to just go against what we know might be good for us. So even as somebody knows intellectually what they should be doing, their behavior does not match with what they know inside their head. So we've really found that that's a very interesting place to start. So what have Kenyans done? The first thing, Kenyans, some of them are not observing, some of us are not observing curfew orders, okay? And some are actively resisting them. I remember in Eldoret at the beginning, there was a huge skirmish somewhere near the stage, the main stage in Eldoret, where the traders said, we're not going to go home. What do you want us to go home and do? We need to be making money for those same families you're telling us to stay with. The second response, that people are attempting to violate the movement violations. When this cessation of movement was put in place, we saw people crossing county lines and the cessation areas willingly, the restricted areas. Others were using tactics of smuggling passengers and others bribing some agents. And you found that Kenyans, and that's why you are finding infections in some counties which didn't have those infections, yet there was a cessation of movement order, because people were breaking the order and they were crossing lines and going there. I remember even there was one case in the county of Nakuru where someone had left Mombasa when they had been quarantined and they ran away. Then they went to Nakuru. Now, then when they went in that estate, everybody ended up being quarantined just because of that exposure. The other thing that we've seen that's a reaction is illicit gatherings. We have seen Kenyans na party. Oh my goodness. Kenyans na party. I do not even understand how we need a national response to partying in Kenya, because you find that there are house parties continuing left, right, and center. We also have seen harambes, public gatherings, political meetings. We've seen a lot of events still going on, directly going against the public gathering and social distancing directives. Some being flouted by government officials themselves, others being flouted by people who say, so you found a lot of arrests. And I remember the one about the young guy with his friends who was arrested when they were smuggled in an ambulance just because they were drunk and they wanted to go home at that night, at that time. So that's what we've seen. We've also seen an increase in crime. The type of crime has mostly been petty crime. So when you talk about petty crime, I'm talking about snatching of phones, I'm talking about pickpocketing, I'm talking about crimes like those ones, which are not necessarily violent crimes, but they are crimes nonetheless, and they are crimes to do with economic hardship. You can tell if someone is stealing your phone, they're stealing your phone to try and go and see if they can sell it so they can actually make some money. We've also seen the psychological impact, of course, as you can imagine. For me, that's front and center. A lot of citizens are anxious right now. People do not have any certainty about the future. There's a lot of job loss. There's a lot of anxiety about when are we going to do anything. And that's why the briefs sometimes are important, because Kenyans want to know, are we opening school? Are we opening the country? Are we going to do this and the other? One of the ways of alleviating that anxiety is by communicating with people in a way that will make them understand it. And finally, one of the ones we've seen that is really sad, of course, is the sexual and gender violence, gender-based violence, as well as, of course, when you see other forms of violence that have increased, you're hearing about families. You've heard about the mother who killed all her 4 children, and of course, we can argue that she probably had an underlying mental condition, mental illness condition. But what I'm saying is that we've seen an upsurge of these violent things that are part of the response to us in this country at this point. So, of course, we would like to see measures in place to combat those kind of things. Okay. What are the conclusions and recommendations of the work that we're doing? Number one, we're seeing that if we want Kenyans to change, and if we want them to change their behavior or to improve their behavior around this pandemic, we have to use the art of persuasion. We cannot coerce people. We have to use language that actually persuades them to actually change their behavior as opposed to coercing them. We cannot talk down to people. We have to find a way of being soft and convincing them to actually change. It's not easy to do that because, of course, even as people are angry telling Kenyans that, it's because they're seeing it's because they're passionate about Kenyans, and they're also very passionate about the lives of Kenyans. So when they tell them, why are you doing this, why are you doing the other, it's not because they don't want to help Kenyans, but it's because they're really passionate about them. So we're saying changing that communication strategy and using persuasion rather than coercion. The second recommendation, we need to deal with the idea of stigma around COVID-19 as well as the socioeconomic impact. Luckily, the eight-plan stimulus, economic stimulus plan, has started being put in place, and hopefully it will help Kenyans. But the idea of stigma, we need to really talk about it because it's starting to remind me of when HIV and AIDS came to Kenya. And when people, if someone was positive, they were looked at strangely, and they were actually not even supported in any way by the community, and they were castigated into the darkness, and they were called immoral, they were called all these things. The same thing when somebody contracts COVID-19 at this point, what is happening is that people are calling them irresponsible, they're calling them many names, and there's a lot of stigma. And I remember when we talked about stigma with this team a few weeks ago, the experiences that you gave us, even just in the front line working with Kenyans, really, really, really touched our hearts. And for me, it became the question that I'm asking. I'm saying, no. I do not want our healthcare workers to be working with this shadow of stigma on their head. The same thing with Kenyans. If they contract the disease, we don't do the same thing when someone contracts diabetes. So we need to really normalize COVID-19 as a medical condition. Finally, or rather, second to last, the community context. We have to remember which communities are we talking about: social distancing, wearing masks, and these other things. Like we really have to work together with communities to make sure that these interventions can translate culturally for them, and especially with spiritually. Like right now, already I can tell you there's a storm about the requirement of people under the age of 13 and the ones over 58 to not attend religious services, and people are really clamoring to get back. But then we have to see, how do you then bring that same community? And luckily, those are a committee of clerics that actually sat down and came up with those directives because of vulnerability and what scientists were saying. And lastly, let us not lie to anybody that there's any country that's an expert. And that's what I love about what you've been doing here, Dr. Kinuthia, Dr. Gumbao, Dr. Kalondu, and your team at KNH. I think that you are actually leading the way in showing that we can actually teach each other as the world goes through this condition together. Behavior change will not be affected just because Mzungu in a corner somewhere said something, or just because another country other than ours came up with a solution. I think that our homegrown solutions that will actually be informed by science, first of all, from around the world, and protocols from WHO and other partners, will be the ones we actually look at. However, we will also think about our own cultural expression, and we'll actually ask ourselves, how can we make it work as a Kenyan question? So, in conclusion, as I keep saying, keep it up. Your work is priceless, really, really, and we're really humbled to keep working with you. So feel free to discuss this. Let us know, does it even make sense? Is it what is on the ground? Are you seeing something different? Can we add to what we already have right now? And because at the end of this pandemic, as I always keep telling you every week, you are the heroes of this pandemic. And without you, this country would not be holding together the way it is right now in the middle of it. So thank you so much for this opportunity. And thank you. Thanks. Back to you, Dr. Kalondu.
Thank you so much, Dr. Gidua, for that wonderful presentation. You brought it very much home, and some things that you've addressed that are already in the Q&A section. I can see Professor Lukoe joined us while we're in session. Professor, would you like to say something?
Thank you very much. I just wanted to apologize that I couldn't join in earlier. I had another meeting that I've finished. But we've worked very closely with Oscar and a team of mental health and behavioral scientists coming up with what we think are some of the best ways of achieving the best results in controlling the pandemic and regarding non-pharmaceutical approaches. We've really worked on this, and I think, I am sure, I caught him towards the end, and I'm sure he did the subject justice. The key emphasis being on, as we do everything possible to control the pandemic, as we try to direct people in the way of protecting themselves and protecting others, ensuring that the language we use is more persuasive rather than coercive, and that the actions that we take demonstrate that we are doing it because we are trying to control an infectious disease rather than just enforcing a law or enforcing an edict. And we have seen that when things are done that way, people are more likely to comply than if you come with orders that you're enforcing with coercion. So I thank Oscar for doing justice to the work that we have been doing together. Thank you.
Thank you so much,
Thank you, Prof.
That. And it's true, Oscar's done justice to the work that you've done together, and also Professor Madai, when she started the session, she also did some justice to it. Now, there's something Professor Madai mentioned about the individual's perception of the threat or the risk, the way they perceive the disease. Going through social media yesterday, there was, I won't call him a celebrity, but I call him a almost well-known person in Kenya who posted a video of himself in hospital on oxygen, and he was saying COVID-19 is real. But the backlash that is gotten today has been quite interesting. People are not believing that somebody in ICU can actually talk. Somebody can actually appear on TV and it looks to be selling into the government agenda. So how do we handle individual perception of the threat? Because right now, that is what is affecting our behavior. As you said, the masks that people are wearing on their neck, people are choosing to focus more on what am I going to eat, where am I going to sleep, my rent. So there are those psychological aspects that we cannot ignore, that we accept and agree, but also how do we also, as healthcare workers, bring the individual to also understand that they're still at risk despite all these things, and it's not a government ploy to derive them of their livelihood or to look for money, whatever out there people talk about. Professor Lukoe.
Yeah, I saw that. The social media, discussion. But I think in the early days, when we had like, 20, 30, 100 people who were infected, then at that point, it was a lot more important for us to worry about convincing people and demonstrating to people that this thing is actually here and that it is serious. As the numbers increase, and in the theory of this exponential spread, in the beginning, you don't know anyone who has been affected. But as time goes by, everybody starts knowing somebody within their circles who has been affected, and some of them who might have died and so on. So it becomes less important to convince people that this thing is serious, and becomes more important to focus on what next. Now that it is here, now that this is what the threat that we have, what mitigation is available, and convincing them that while it is risky, it is not such an existential threat that you should do things that are self-defeating, that become even more harmful than the intervention itself. So I think it is inevitable that you will have, as long as government doesn't have a hand in it, it is inevitable that you'll start having people who randomly take to social media to give their experiences, and they will do it the same way any amateur communicator would do it, by trying to say, listen, I went through it, it was so bad, nobody should get it, or somebody else who will say, no, listen, I went through it and it was nothing. I experienced nothing and I'm okay. And our role as healthcare workers is to validate both those views and to continue giving the factual information that yes, the majority will feel like this, but the few who will feel like this will become, are important enough for us to focus on to try and prevent ourselves from going into that severe end of the spectrum. So it is our role really to continue correcting the misperceptions, continue providing accurate and timely information, and to continue providing information about the kind of care that is available at this point in time and where people should go for care. And not get drawn into arguments about whether it is a government ploy to deny people's freedoms, whether it is a government ploy to do one or two things to steal money and so on. Those will be conversations in social media. But as experts, we'll be coming in to say, no matter what anybody else is doing about this pandemic, these are the facts around it. So I think that is our role as healthcare workers, not to be drawn into trying to argue too much around the conspiracy theories, especially when we have now thousands of cases around, but to focus more on the truthful information and debunking scientific myths and providing accurate information instead.
Thank you for that. Dr. Gidua, you talked about persuasion rather than coercion as one of the recommendations that was made, and I think that's a very good suggestion. Now, we've seen quite a lot of communication strategies which the Ministry of Health has put in place. Also on the KMA website, you'll find quite a lot of information about commercial corona, especially on their Facebook page. They've been pretty active about it. There's the avoid the 3 C's, reasons for wearing masks, that is humility, kindness, community, the new normal, stigma. The ministry level, they have the risk assessment chart, which is making its rounds in the social media pages. Dr. Gidua, do you think this is persuasive enough, or should we go an extra mile as healthcare workers to really convince our colleagues plus the general public that their response they still need to be very careful about their behavior out there in public?
Well, thank you so much, Doc. And even before I answer your question, Prof. Lukoya, welcome again. Thank you. It's great to see you. I told the whole team about our work. I gave them a bit of a synopsis, and I also introduced the whole team to them, so at least you can be apprised of that fact. So, Dr. Kalondu, to your question about, if we have done enough, definitely we've not done enough. I mean, that's a simple, fast answer that we've not done enough. However, we can actually start building on what we already have. So, for instance, the reason why there's that backlash on whoever the celebrity or the famous person is because sometimes when you look at somebody speaking, the first thing that human beings like to do is they ask themselves, do I see myself in this person? Is it probable? Is it even probable that a person like this could actually contract it? So, you see, like the case of Brazil, and I think one of the participants has actually put it over here on the comment section. The Brazilian president was actually demonstrating, interestingly, with people on the ground, and he was saying, no, open up the country, open up. He just tested positive today for coronavirus. So you have to understand that sometimes it's just about, it depends on who is the person communicating. What they're communicating sometimes might be as equally important as who the communicator is. So if the person talking is someone people cannot relate with or cannot relate to, then the message can be lost because of the messenger as opposed to the message. So on the KMA web page, I think it's really great that you've mentioned it. It's great. It's good for medics. It's good for their clientele. It's good for the people you serve. But let me ask you, how many people actually get a chance to interact with your people on a consistent basis? And how many of the good people from KMA actually have access to the common humanity on the ground, apart from the work when they enter into the clinics, into the hospitals, or do they have a public sphere where they can actually share? So it is very important, I think, that we look at this persuasive strategy as not coming from a top-down approach, but it probably applying a peer approach. If young people can tell other young people to stop holding the brushes, if other people can tell each other to wash hands, it sounds more probable and better than being told from on top, because people will get tired. It's almost like children and their parents. The parent will tell you what's good for you. You'll keep hearing it, but you'll still contravening it. And as I've said when we were presenting that, even if people know what is good for them, sometimes they will not act in that direction. Not because they're bad, but just because it's a human condition. I think to crack that, we need to think of, is the person relaying the message relatable too? And that's, for us in this forum, for instance, we will listen to each other because we are peers to some degree. But then if you're communicating to someone who is in a different setting, they might not listen to our message the same way. So I think for me, it's messenger is as important to me as the message. Thanks.
I think it's true. The messenger is as important as the message. And this brings me to my next question, Professor Madai. Hello, Professor Madai.
Yes. I've unmuted.
Yes, you took us through the learning theory where you said the healthcare worker educating the patient and demonstrating the protective skill. The healthcare worker, are we modeling the appropriate behavior? As healthcare workers, are we complementing appropriate behavior? Now, I love to think of the healthcare worker as in the same lenses that I use to view the general public or to view my brothers and my sisters. And my question is with regards to the knowledge, because the healthcare worker is the person we're expecting to communicate to the patients, to the general public, to their relatives, and to the society and community overall. So do you think that the healthcare worker, we've equipped the healthcare worker well enough to have enough knowledge to be able to preach the message of behavior change currently as we are, other than the statistics that we see every day in the news, the press briefing? Have we as the ministry invested enough to ensure, or as the individual doctor, because now it's an individual, there's a part where now it's the government and there's a part where now it's an individual. Do you think we've invested enough to gain enough knowledge to be able to promote behavior change as healthcare workers?
Okay, the question of whether it's enough, until this pandemic is over, nothing we're doing is enough. So we have to keep doing it. And of course, you people are the ones who are doing these webinars every week. I mean, I'm amazed at your energy and persistence, because this is an education forum which has proved to be very popular and which is attended by a lot of health workers. I don't want to put, like you say, view your health workers as like your brothers, yes, in the health profession, but not like everybody else, because these are people who do not need a policeman to tell them to do this, because they know. In fact, they should be the ones who are educating the policemen, you know. So they don't, as a health worker, you don't, you're really at another level. You should be able to understand this better than the public. You still need education, but one of the problem, Dr. Kalondu, with this COVID is, like we said, the mixed messages that have come from the scientific profession. I'm sure you all remember the pandemic video that went round, and so it has, and even in our context, I have been fighting misinformation and infodemics within groups that WhatsApp groups of College of Health Sciences, and I'm always like, no, this can't be happening. You know, this can't be happening. So we still need to continue doing this, and I hope that this project that you have doesn't get tired until this thing is behind us, because we all need to be reminded. And again, I say it is important for us not only to every contact that we make to give the information, like Professor Lukoya has said, facts, demonstrate what you're talking about. If it's a mask, you know, take that time, the same way we used to demonstrate how to use a condom. When you see somebody, when you're in contact with the young people, you say, and this is how you use a condom, you take it and you demonstrate, you know. So I think it's not, we cannot stop, we cannot say that it's enough, but I think we definitely have a role to play, and it's a very important role. Thank you.
Thank you, Professor Madai. And it's true, we have an important role to play. And this leads me now to the Q&A section. And somebody is asking, due to the perceived mistrust, actually the question starts from, how does one overcome the perceived barriers, especially the social and economic ones, as experienced during the prolonged lockdown? In addition, due to the perceived mistrust to the primary source of information, that is the government, will changing the source have a greater impact on behavior change? Professor Lukoye, if we allow various parties to bring the information, we have a little of information from here, a little from there, instead of having a centralized source of information, would this have an impact on our behavior?
Yeah, so the reason why during pandemics there is coordinated collection of information and there is release of information from one source is to avoid a situation where even slight differences in messaging create misunderstandings in the population. So we could, for instance, come here and say, you know, one party might say it is important to use masks when you go out into public spaces, and another one says, no, you don't have to use a mask when you are in your own house, or you don't have to use a surgical mask, you can use a cloth mask. And then we seem to be disagreeing on a small point like that, but it is magnified out there to such an extent that the message becomes the doctors cannot agree on whether you should wear a mask or not. So that undermines the intention of the messaging. And you have seen a lot of this on the international scene, where WHO advises one thing, then CDC advises the same thing, but then with slightly different language. And then it looks like CDC and WHO are saying totally different things, and people arrive at their own conclusions. So it is important to have one source of information. As professionals, our role becomes to support that one source of information, to have the most accurate, most evidence-based information, so that when it goes out there, we are able to support it. Whenever people come to ask us, does this make sense? We would also be able to say, yes, this makes sense. So in a pandemic, just like in any wide-scale project, even if you're building a big house, you can't have everybody coming and giving their opinion that this is how it should look like, this is what should be done. There has to be somebody who holds the ultimate message, somebody who communicates the overall vision and mission of what we are doing and why we are doing it, rather than having disparate voices. So while it might be the case that we don't trust government that much, it is one of the things that we have to live with. That as long as society is organized the way it is, as long as government holds the ultimate responsibility to ensure that we are healthy, then it falls on the government to communicate to us what needs to be done and how it needs to be done in order for everyone to be healthy.
Thank you. And that also addresses a question that I'm seeing somebody asking about addressing conflicting actions. It addresses that. And as Professor Lukoye said, it is our responsibility as healthcare workers to support the actions. Of course, we need to understand what action the government is taking, so we need to update ourselves. And I love that the Ministry of Health website, every day or every week, they update on the situation analysis. Down there, there's a folder on COVID-19. Please update yourself. I know they last updated it on 4th of July, but they've been updating it frequently, and also the week, how the week situation has been. It is very good that you get that information. It is available at your disposal. Please get the information so that as you try to educate, your people will ask you questions. You're talking from a point of information, not from your own personal opinion. Thank you for that, Professor Lukoye. Professor Madai, there's a question from Dr. Wambani, and she's asking, what programs can be rolled out in the community to promote behavior change without stigma?
Yeah, that's a tall question. What programs can be rolled out to promote behavior change without stigma? I'm trying to think. I haven't really thought about that, but the one thing that I really know that works well is when people in the community are used in the development and the design of these projects. When you use people in the, for example, if your target group is the youth, don't go and make up projects for the youth in your offices and then you bring it to them. If you want it to be for the community, please involve the community. Go sit with the community. This is the problem that we have. How in this community can we implement this project? Because it's like I said, you know, remember that picture of the chalk, that you can go and tell them to build latrines, and they will build the latrines because they don't want to be fined by the public health officer. But they will say, ile ni choo ya public health officer. At least that's what we used to learn in community health. And a lot of these projects, the country is littered with projects like that. So Dr. Wambani, involve the community. Go with your knowledge, your facts, and your evidence, but let them be part of that. Let them own the project. That's the best I can do for that question. It's a hard question. But maybe Professor Atwoli has some ideas on that as well, because I know he's involved in a lot of community-based projects.
I think, Madai, you have really treated that very well. I think the key in avoiding stigma is in, as you've correctly said, having firstly the messenger looking like the people for whom the message has been crafted. So that helps a bit, because they're like, okay, he's one of us, he can't be, you know, picking these things out of the air. So that is important. But secondly is ensuring that all the information that you are consistently giving out is trustworthy and trusted information, to ensure that people now know where to go when they need information. So for me, that would be an important aspect. And then thirdly, there's the issue of modeling. You know, when you tell people to do something, you should also be doing it. Don't be telling them, do as I say, but not as I do. So when you're going to talk about people wearing masks, you should be wearing a mask yourself. When you say people should keep physical distancing, you should consistently communicate physically, showing that you are physically distanced. When you talk about any behavioral intervention, you should be the first one to demonstrate that this is a behavior that is desired and this is a behavior that is not desired. That way you chip away at the ignorance that drives stigma, you chip away at the prejudicial attitudes that drive stigma, and eventually you change the behavior, which is the goal of all these interventions. So I think that is, in summary, how I would look at if you're designing a information campaign in the community, how you should do it in a way that is aware that you can worsen the stigma if you do it badly.
All right, thank you so much, Professor Madai and Professor Atwoli, for that input. There's a very interesting question from Dr. Wilberforce Cabero from Mulago, and is asking, what do we do and what model do we apply when the community becomes complacent on preventive measures? His other question, and this is directed to Dr. Gidua, is asking, what should we do when the community also has community fatigue of partial lockdown, curfew, quarantine, yet it seems that they are still in play till the pandemic is over? So how do we encourage or persuade the community to still continue being engaged? And yes.
I think that's a very good question. I think, Dr. Wilberforce, because that fatigue is not going to go away. And I think at the beginning of these presentations, we talked about how to view COVID-19 or any epidemic for that matter, or pandemic, is not to look at it as a 100-meter dash, but to look at it as a marathon. So the idea is, if we do not address the question of telling people the truth or just being open with them about how long we anticipate this to last, we will not be doing ourselves a good service. Because, for instance, every time when His Excellency the President is about to speak, you hear people asking, atafungua, atafungua, atafungua. That had been the thing until before the day before yesterday. But then if you really examine it closely, it's because people were actually more, because if you look at how people's lives have actually changed, apart from those who will be traveling outside the cessation of cessation of movement containment areas, if you really think about it, people's lives won't change that much because the curfew had actually been pushed up to about 9 p.m. So it's just the perception of being locked up that people don't like. It's almost like I just want to know that I'm free to do whatever I want to do if I need to do it, even if I'm not planning to do it. So it's almost like for Kenyans, we have to find the best titration of time, of how do we communicate with Kenyans, tell them we're in this together. How do we communicate with them and then not create the different classes that I was talking about, the people who the pandemic is meant for, the ones it's not meant for? How do we increase everybody's idea of perception of risk? Because that is, I think, the other thing that will reduce people's fatigue. The reality is that as human and social beings, as we started by saying, we want to interact with each other and we'd like to actually be seeing each other more. And that's what's causing that fatigue. It's not really the fact that we are in our houses, because really many people are in their houses almost daily, but it is just the idea that we know we cannot interact with other people. We can't do those community and cultural things that we're used to, especially the idea of the spiritual gathering. That's why it was a hot button issue. Those are the things. So I think the people who are advising the government directly and the people in the Ministry of Health must take into consideration the question of how do we make this marathon be bearable? So it's how do we systemically reduce that? And how do we increase social support for people? Because even as the economic effects start biting people, how do we have a social net of some kind that will protect people from those effects? And that is what is really, really hurting people. And I think, to answer Dr. Wilberforce, not that I have the answer completely, I think that we can begin by starting to reason together and say that I don't think that government, and probably just to be in tandem with what Professor Atwoli as well as Professor Madai said, that the community must be involved. And that's what I was saying as one of our recommendations, that community interventions, community must be involved. What is going to be comfortable per community while still adhering to these directives from the World Health Organization, CDC, Africa CDC, and the rest. So I think it's just a balance. Nobody, and as I said in the last one, nobody can claim to be the expert. So in reality, the whole world is facing this fatigue together for the first time. And I think we're going to learn together. That's where I can begin, but I can't claim to be the expert on that. Thank you so much.
Thank you, Dr. Gidua, for that response. And it's true. It is a perception that we have, and it's not that it is not helpful. The measures that have been put in place are very helpful, and we need to continue engaging the community, still appreciating them for the effort that they take, and also encouraging them as healthcare workers to continue adhering to that. So the education has to continue. We cannot afford to stop. There's a question about behavioral modeling, that it requires a lot well thought out messaging. In spite of everything that professionals may do, the government hasn't quite figured out the messaging thing when attempting to reach out to the younger generation. How do we support the government to do better? Professor Atwoli, how do we support the government to do better?
Yeah, I think this is what we've been saying, that start by looking at who is your messenger, because the message, we have the message down pat. We are clear about what needs to be communicated. It is the how and the who that needs to be worked on. So if you're going to communicate with young people in the informal settlements of Nairobi, then you should first speak the language that people speak in those areas. And I've seen an initiative where this messaging that goes out about washing hands, about physical distancing, about the risks associated with COVID-19 being translated into street language and being communicated to young people in that way. And it makes more sense to them. Incorporating these young people into the teams that craft the messages and create the graphics and so on. Young people have a lot of energy, have a lot of ideas. If you bring them in a room and tell them, this is what I'm trying to communicate, you'll be amazed at the kind of messaging they will come up with and the kind of graphics. We have seen them using graffiti to communicate very clearly, very poignant messages in some of the slums in Nairobi. And we young people, I think we underestimate their imagination, we underestimate the intelligence, we underestimate just how much they can bring to the table when it comes to messaging. And the day we start using them, it will be a lot more effective than when we bring, we are correct, we are scientific, we are using simple language. The training in communication that we received was that you speak as if you're speaking to a 12-year-old or something so that everybody can understand, but it doesn't work if you're speaking it in the voice of an old man. It doesn't work if you're speaking a 12-year-old's language and the face is the face of an old man. So we have to think about it holistically, so that a person who looks like me is speaking a message that makes sense in a language that I understand and speak on a daily basis. That's the only way I think that we will be able to reach these various segments. So we can get the same message and craft it in different ways in order to reach different people. You can craft it in Somali so that it can be something that is popular in Garissa, and we have seen efforts at getting people to act out these messages in a way that makes sense to people in the community. So at the basic level is to think we have the message, let us craft it in a language that makes sense to the people we are going to communicate to, and let us get the messenger who's going to communicate the message be someone who looks like the people we are going to communicate to. At the very basic level, that should work.
Okay. Thank you so much, Professor Atwele. And it's true, that is the best age to craft messages for their age group. And as you've said, in most cases, we undermine the energy and the effort of the young people. So it's time we involve them in this to craft the messages. When we had a session on communication strategies and the measures that have been put in place towards communicating about COVID-19 disease, the presenter mentioned that they've involved different age groups to craft different messages. So probably we have not gotten access to the platform where the young people are, the younger generation. But what they said is that the team that is working with the ministry has crafted messages targeting the younger people, targeting the older age group. So every age group has a team that is working on that messaging. We'll find out more about that information and where the messaging and how it's packaged, and then we'll come back again with another session on communication. The last question, and this goes to Professor Madai and probably Gidua and Professor Atwele, and somebody is asking, are there any lessons we've learned from the HIV response on behavior change that we can apply to COVID? That's the last question before we end the session. So we'll start with Professor Madai. Yes.
Yeah, thank you very much. I think, in fact, we can apply a lot of the lessons that we have learned from HIV/AIDS, whether it's about stigma, whether it is about messaging, whether it is about behavior change. We can apply a lot of them to the COVID-19, and even about programs, the programs that have failed. What has worked in HIV is also likely to work here, even though the mode of transmission is different. So we have a lot to learn. And if you don't mind, let me just respond also to this thing about the teenage pregnancy very briefly. That what somebody said very early on is that what this COVID-19 has brought out are the problems of society, the cracks in a society, and what we have ignored for a long time. We have ignored for a long time that a big percentage of our Kenyans don't have clean water, don't have running water. We have ignored that they live in overcrowded places. We have ignored that teenagers are sexually active, and we have decided to bury our heads in the dust or sand and say they should be abstinent. We have refused to support them, to say, okay, teenagers, if they are sexually active, we need to give them the skills to protect themselves. And so that is what the problem is. It's not that teenage pregnancy is new. It's just that some of these things are popping up because our social fold, the society sort of net has been severely disrupted. Thank you.
Thank you. Thank you for also addressing the issue of the teenage pregnancies. Dr. Gideon?
Yes. Oh, thank you. Thank you so much, Dr. Kalondu. Let me take an interesting take on especially the lessons from HIV. I know that there are many lessons we can learn, and of course, as our professor has very articulately said, in terms of messaging and in terms of age groups and all of that. But there's one thing I want us to consider about the HIV pandemic that is a bit different from COVID. HIV, the reason why it ravaged our continent mostly more than other, one of the reasons, not the only reason, but one of the reasons is because for Africans, when you mention sex and you mention death in the same sentence, you have really now confused them completely. And because those topics are taboo topics to be handled by certain segments of society only, what ended up happening was that the message did not reach soon enough because people had to pretend that they were not engaging either in having sex, and they had to also pretend that the reasons why they were dying was not because of this disease caused by the virus, but it was because of being cast or other things. If you look at COVID-19, the behavior change we're asking people to do does not have a moral component to it. HIV had the moral component of, what is sexuality? If you die, there's curses. There's all these mysticism that is an African concept. But then when we look at COVID-19, when you're telling someone to wash their hands, it's really not anything to do with their morals. And even when you talk about social distancing, it's not about anything moral. So the at least with HIV, there's a chance that if you're telling people to abstain from sex, there's a moral component to it as well, which already society was backing up by saying that probably if you're a teenager, you should not be engaging in sex before a certain time or whatever it might be. The messaging was supported by cultural practices. But when it comes to COVID, the idea of social distancing is the very opposite of what Africans like to do. So I want to suggest that we can learn a lot from HIV, but at the same time, I think we need to be the most creative in this pandemic, because it provides for us an opportunity to say these things that are very African to us, like being so close and having these religious services and doing things together communally. Can we be able to message within that context of the things we love, and then assure people that we are not dropping our culture, but that actually we are suspending our culture, so to speak, or we are transforming our culture? So for me, that's where the argument would come and say that maybe the difference between HIV and COVID is the moral component and the kind of messaging that we'd have to craft. Of course, like I want to agree with the professors and everyone else that the truth is that the two infections are very different, of course, and they're not caused by the same pathways. We just have to start asking ourselves, for these COVID-19 infection, which is saying it's a 0.3 micron large particle, how do we apply a message? How do we apply messaging? And how do we apply a strategy that will address something that we cannot see? Of course, we can't see any of the pathogens, but something that actually does not also tell us like we're trying to crash our culture. That is our biggest issue, and we need to think around that. And it's an exciting time for us to craft something around that, but I think this is what we have to look at. Thank you so much.
Thank you. Professor Atoli?
Yeah, thank you very much. So I've heard a lot about us learning lessons from the HIV pandemic, and I fully agree, especially around messaging, that there's a lot to learn about what to do and what not to do. For me, though, the biggest difference between HIV, and therefore, I mean, my caution that we shouldn't overplay what we learned about HIV is partly what Oscar said about the mode of transmission, and there are loads and loads of morality bound around HIV. But beyond that, the big difference is that HIV, believe it or not, gives us time in which to craft messaging and to be gradual and to be gentle and to be thoughtful and so on. HIV gives us time for the simple reason that it doesn't spread, I mean, you could almost say it doesn't spread involuntarily compared to COVID-19. You will not catch HIV by sitting next to somebody who has HIV, or by even hugging them, or by walking in the street with people of unknown status. And that is a big difference with COVID-19, that the messaging, for COVID-19, you don't have time. COVID-19 is here. You can get it even if you just sit still in one place and people pass around you. And so the messaging has to take into consideration that fact, that big difference between HIV and COVID-19. In fact, in HIV, you could argue that when you privilege personal agency by saying that as an individual, if you do certain things right and keep doing them consistently, your chances of getting HIV are close to nil. With the COVID-19, that doesn't seem to hold, especially when there's widespread community transmission. The fact that somebody else around you, whom you're trying very much to be careful around, you could still get the infection from them, is a difference in messaging. And so we must emphasize a lot more of the social solidarity of taking care of other people. If you're going to invoke African tradition and charity, then you should invoke that solidarity aspect that we Africans, we are, I am because you are, because everyone else is. And therefore I cannot be okay if other people are not okay around me. And that is the basis of the communication. Take care of the wazes in the villages, take care of the children, take care of the strangers that you're going to hang around with. And what do you need to do to take care of them? These are the things you can do yourself that will protect them to some extent. So for me, the difference, those differences in the type of infections that we're talking about mean that, as Oscar says, we have to be a lot more creative around COVID-19 messaging. And remembering that once you get it, often within 2 to 4 weeks, you do not have it. And so applying the same long-term messaging for HIV might not apply in this case. We have to be a lot more creative, a lot more nimble, so that our messaging changes quickly around the changes in knowledge, which are also happening extremely fast. And that is a huge difference between what we can do for COVID-19 and what we did for HIV. Thank you.
Thank you so much, Professor Lukoy. Due to time, kindly allow me to end this session. I'd like to appreciate Professor Mathai, Dr. Gidua, and Professor Lukoy who joined us to make this session very interesting and to actually talk to us about behavior change. I really hope all the participants who've listened in today will be agents of change. The change has to start with you. And as we learned in the learning theory, that it is our responsibility as healthcare workers to educate the patients and demonstrate. They will learn, patients will learn through our actions. So demonstrate the protective skills. We also have to model the appropriate behavior and to complement. A simple example is the one Professor Mathai gave, that when somebody comes into your clinic and or into your department and they're wearing a mask, you compliment them for that. Also, we learned about the health belief model to COVID-19. We will be sharing the presentations with you, so no need to write us email, we will just upload them. And there's the issue about the recommendations that were made that Dr. Gidua presented, that we need to take an approach of persuading the general public rather than coercing them. Let's not use force, but if we convince them, and we have to convince somebody from a point of knowledge, then they will be able to buy into the behavior change that we want them, sustained behavior change. If we coerce them, then it will be temporary behavior change, and immediately you turn your back, they go back to what they were doing before. But we are hoping to have sustained behavior change, so persuasion rather than coercion. Then there's the stigma, social economic impact, the community context, and also learning as we go. So thank you so much for attending today's session. We'd like to appreciate everyone who found time to attend the session. Tomorrow's session will be at night, 7 to 8:30. We'll be talking about pediatric COVID protocols. We'll be doing a comparison of how they manage their pediatric cases in Seattle and how we've managed our pediatric cases in Kenya. So that will be a very interesting one. And have a good afternoon. Bye. Thank you.
Bye-bye.
All right, thank you.
Thank you so much.